to welcome you all to our 30th Libyan cardiovascular webinar. Thank you very much all for attending. It's my pleasure to introduce the first speaker, who is a good friend of mine and a colleague, Dr. Yusuf Adarat, who's a clinical cardiac electrophysiologist in the USA. He is going to speak about the usual suspect or the unusual suspect of ST elevation. Yusuf, the floor is yours.
Assalamu alaikum. Shukran ya Khalid. Assalamu alaikum, everyone. Thanks for spending time with us today for this presentation and the webinar. I'm going to talk about the unusual, which I call not the usual suspects of ST elevation, not the usual suspects. I have a total of 3 cases. So what we'll do is go over the scenario, and then I'm going to post some questions, and would like you to participate and give me the best choice you think would be for each case. So the first case is a 42-year-old Caucasian male with no significant past medical history, complaining of some occasional, really more of an atypical chest pain. Has family history of premature coronary artery disease. His he was establishing care of the primary care doctor, and due to the past family history of premature coronary artery disease, she obtained a 12-lead EKG, which I'll show you now. So you can take a few seconds here to look at that 12-lead EKG. Again, this is a 42-year-old male, has occasional chest pain. And this EKG was done as kind of more of a screening EKG. So based on this 12-lead EKG, I'm going to post the question now. Okay, so choices are, based on this 12-lead EKG, what would you recommend? A left heart catheterization, stat echocardiogram, genetic screening, or reassure the patient. Please vote now. And as Khalid mentioned, you can click on the magnifying glass in the middle of the image, and if you want to take a closer look at the EKG. Okay. So most people chose genetic screening. So left heart catheterization. I would not recommend the left heart. So the EKG shows ST elevation in the right precordial leads, mostly right precordial leads. No reciprocal changes in the other leads and the inferior leads, and it's more consistent with the Brugada type 1 pattern, where there's an elevated J point, there's an ST elevation. And this EKG looks typical for a spontaneous type 1 EKG. Therefore, left heart catheterization, I mean, his chest pain is occasional, mostly non-cardiac chest pain, lasts for a few seconds, more kind of a sharp chest pain. So I wouldn't really recommend the left heart catheterization. Second choice, stat echocardiogram. I don't think that's going to show anything. It's obvious. I mean, you could do an echocardiogram if you suspect, in this case, in this particular EKG, maybe arrhythmogenic right ventricular space dysplasia. There might be some overlap, though this EKG is more typical for Brugada type 1. Then the second choice, genetic screening. Yeah, genetic screening would be the most appropriate answer. This is the next thing that you want to discuss with the patient, though the yield is only 30%. And then the last choice is reassure the patient. I would not reassure the patient. With spontaneous type 1 EKG, there's risk of sudden cardiac arrest of about any risk of about around 1%, 1 to 2%. Higher, definitely higher than the general population. And I would recommend, of course, one of the most important things we'd like to ask the patients about history of syncope, a history of sudden cardiac arrest. Those are the things that would help you in determining the next step. So in this patient, he hasn't had any history of sudden cardiac arrest, no history of syncope, all he has some occasional chest pain, and therefore the next best step is to order genetic screening. So next question, what should you advise the patient? So we know this is a type 1 E. pattern Brugada, and what would be the your advice? Avoid high fever by using antipyretics, avoid sodium channel blockers and beta blockers, avoid exercise, all the above, or all except number 3. Please vote now. Okay, so no one chose avoid high fever by using antipyretics, avoid sodium channel blockers, avoid exercise, all of the above except 3. So there's something in the way here that I can see. So definitely the best answer here is all except 3. So patients would go back to, so patients with Brugada syndrome, there with fever, there's been shown that there's increased ST elevation, possibly increased risk of sudden cardiac arrest. So definitely one of the things that you would recommend your patient is to avoid high fevers by using antipyretics and trying to aggressively manage fever. You can see here, this is a slide that I got from the journal that shows the EKG changes at baseline. So the baseline you can see here, this is the patient's EKG at 37 Celsius. So it looks kind of more normal EKG, very subtle ST elevation here. But with the temperature of 39.3 in the same patient, you can very obviously see the ST elevation, very elevated J point ST elevation, very consistent with Brugada pattern EKG. And this has been shown, it has to do more with the inactivation of sodium channels with high fever. So what Brugada is basically, it is loss of function in sodium channels, the alpha subunit of sodium channel, and therefore if you further decompensate or affect the sodium channel functionality, then it would make things worse. And it even if there's some subtle changes, it could show up with sodium channel blockade, fever, which can cause inactivation of sodium channels. The second answer was avoid sodium channel blockers and beta blockers. Definitely this has to be avoided. Beta blocker should be avoided in patients with Brugada syndrome, and avoid the sodium channel blocker, like I explained, that it blocks sodium channels and makes the loss of function of sodium channels worse. Exercise, actually, there's no data against exercise in Brugada syndrome. The only syndrome that I can definitely that you should avoid exercise is arrhythmogenic right ventricular dysphasia, but not specifically Brugada syndrome. Though I've actually, you can see here, there's a reference about worsening of segment elevation during the recovery phase of exercise stress test. It's been shown that during the recovery phase, ST segment elevation can happen in Brugada patient. This is for our EP folks who are joining us today. Actually, this is a study of about 93 or 98 patients that they risk stratify those patients who have ST elevation in recovery period and showed that they are at risk of sudden cardiac arrest. Actually, we have a family here that we've been following. They have Brugada syndrome, and their ST segment, and actually they had sudden cardiac arrest with exercise. But generally speaking, it's not generally a known concept to avoid exercise in Brugada patients, but it's something to consider in some patients. And you can use an exercise stress test to stratify those patients. So the best answer would be number 5, which is avoid all except exercise. Then we'll go to, the next question is, genetic screening was not performed, patient is concerned, what's your best next step? So what can you offer to this patient? Let's vote now. There's 4 choices: EP study, ICD, use of quinidine, which is a class 1 agent, and or use of a beta blocker. Okay, so genetic screening was not performed, and patients still concerned. What's your next step? We have mostly people answered EP study, 42%, ICD 14%, quinidine 14%. None has answered beta blocker, which is the right thing to do. No beta blockers. We've just explained that. EP study. There's data that EP study could be used for risk stratification in patients who have asymptomatic Brugada syndrome. Actually, there was a recent paper by Brugada, the Brugada group, published in Circulation, showing 20 years of experience with EP study, and that's a good prognostic and tool for those patients who are asymptomatic. So EP study would be the next step. ICD could be recommended to the patient since their risk of sudden cardiac arrest is higher than the general population. But again, there's no strong data to support that. Quinidine is not our first choice. Quinidine could be added in patients who already have an ICD and have been shocked. So quinidine can be used, but not as a first line. Therefore, or in patients who have contraindication to an ICD, maybe quinidine could be used, but not specifically in this patient. We have a question from Dr. Sunni. Was the premature family history of coronary heart disease documented and confirmed, or was there sudden cardiac arrest? There was actually family history of coronary heart disease, but no sudden cardiac arrest at all. No family history of sudden cardiac arrest. Okay. So based on, just to support what I've mentioned, this is the guidelines, the Heart Rhythm Society and the European Society guidelines, showing that the first step in if someone who has prior cardiac arrest or sustained VT, definitely an ICD is the first choice. If someone has spontaneous type 1 EKG, family history of syncope, and has a history, personal history of syncope, suspected because of ventricular arrhythmia, then ICD is recommended. If no, then EP study could be used, and if you can use VF or polymorphic VT or sustained VT, then ICD may be considered. And then if there's no EP study, patients asymptomatic with drug-induced type 1 ECG. So this patient is actually a bit different. He has a spontaneous type 1 ECG. We'll talk about induction of type 1 EKG shortly, but ICD is not recommended if the patient has a type 1 or a type 2 or type 3 EKG and they're asymptomatic, then ICD is not recommended. But what pertains to our patient is that he didn't have any, he has a spontaneous type 1, no history of syncope, no history of sudden cardiac arrest, so EP study was done, it's negative, and therefore ICD was not recommended. In this patient, actually, I discussed with him putting a loop recorder. I put a loop recorder to see. He's had some symptoms, very vague symptoms of dizziness. So I just recommended I talked to him and decided to put the loop recorder in. So what is Brugada syndrome? It's SCN5A gene mutation, which encodes the alpha subunit of cardiac sodium channel. This is a type 1 ECG, which very similar to the patient we had. Basically elevated J point with ST elevation of more than 2 millimeters. You can see type 2, and this is a coved appearance. That's what they call a coved, C-O-V-E-D, coved appearance. And this is a saddle-shaped appearance of the elevation, suggestive of type 2 Brugada, more than 2 millimeter of J point elevation. If it's less than that, then it's a type 3. So type 2 and type 3, the difference is that it depends on the number of small squares. How many is it? One or two? That's the difference between both. But basically, the management for type 2 or type 3 is very similar. Type 1 is the one that we worry about because they are definitely at a higher risk of sudden cardiac arrest. Why do we see the changes with Brugada syndrome? Why do we see the EKG changes? There's different theories. I mean, there's a repolarization theory and depolarization theory, but I'll want to explain the action potential. So the action potential is not the same across the myocardium. Actually, in different parts of the heart, it's not the same. So if you remember from medical school, the action potential, you can have a zero phase, phase 1, 2, and 3, and 4, and there's a certain pattern that we always remember. There's different parts actually of the heart have different durations of action potential. Some have a longer action potential duration, others have a shorter, longer repolarization, and so on. So in the epicardium is actually a shorter action potential. Typically, the epicardium, the outside part, there's a spike and dome pattern. So you can see here spike and dome pattern. The reason is because there's more abundancy of ITO channels. Those are potassium channels that cause repolarization, so lead to a shorter action potential and kind of faster repolarization. The myocardium has the myocardium, which is between, kind of sandwiches between the epicardium and endocardium, has a longer action potential. The endocardium, on the other hand, has an action potential that's a little bit shorter than the epicardium. So the shortest action potential is actually on the epicardium. And I'll go to this is a slide that shows, kind of puts things together. This is how it normally looks like. I mean, if you combine the activation of the heart muscle on the endocardium and epicardium and myocardium, you'll have this kind of pattern on your surface EKG. But if you have a very short action potential based on the because you don't have sodium channel functioning in the epicardium, the ITO channels kind of take over, and they have a more exaggerated shortening of the action potential and faster repolarization will lead to the typical pathognomonic EKG pattern in Brugada syndrome, kind of shorter shorter action potential in the epicardium, and will lead to this pattern. You can see here that this is the saddleback appearance, this is the cold appearance. I hope that everyone got this point. We can discuss later, but it's basically, this is one of the theories. The other theory is based on that the RVOT has a shorter action potential compared to the RV, and the combination of both, you'd have this cold appearance. So that's another theory. And there's our people who support this and so what. I think that maybe the first theory is more acceptable. Especially that ITO channels are more predominantly abundant in males. In Brugada syndrome, patients are mostly males. I think it's like 1:8 or 1:9 ratio. That might explain the difference in male to female ratio. There's a theory that also hormones has to do with it, but I'm not really sure about that. So risk stratification, if you look at the general Brugada patients, most patients will fall in the negative baseline EKG with or without symptoms. Those patients are low risk, maybe have a type 2 or type 3 pattern EKG. So if you have someone with type 2 or type 3 pattern EKG, those are the most patients we see. And those are without syncope are at low risk. If the patient has syncope, then further plans should be performed, and we'll talk about that. Then if the intermediate risk is spontaneous type 1 ECG, and they constitute about 41% of the general population of Brugada syndrome patients, and they are at higher risk. The hazard ratio is 2.1. You can tell the patients your annual risk of death is about 1 to 2% if you have a spontaneous type 1 ECG. Then the highest risk are those patients have symptoms, syncope, spontaneous type 1 ECG. Those are the highest risk, and therefore that's why an ICD is recommended. So we'll move on to this case 2. A 31-year-old Asian male with recurrent episodes of palpitations and dizziness, been occurring for the past 3 weeks, going on for about 2 months, actually occur every few weeks for the past 2 months. He has no history of syncope. So I'll show you his EKG, and then Khalid, you can open the vote. Okay. So answers. Most are in favor of repeat EKG with the high right precordial lead, which I think is the correct answer or the best step while you're seeing the patient in clinic. Very simple thing to do. So basically, the EKG shows a type 2 pattern. If you look at lead 2, there's the saddle-shaped appearance of the ECG. It's here. There's more than 2 millimeter elevation, more consistent with type 2 pattern EKG. In those patients, there's two things. I mean, you can do. The first easy step you can do is just have the patient put V2. So usually V1 and V2, we put them on the fourth intercostal space. V1 is on the right peristernal, V2 in the left peristernal. So all you need to do is put V1 in the third intercostal space, and V2 also in the third intercostal space, and then up one more to the second intercostal space. And in patients, been shown that it may reveal the saddle, the coved appearance, EKG coved appearance, and that would be a positive ECG for Brugada. And this patient actually didn't show that. I've also the actual EKGs of the patient. You can see here really very subtle changes. I mean, not really consistent with a coved appearance. And you can argue in the second intercostal space, it kind of mostly looks cold, but there's no significant ST elevation. So this is the slide here to support that. If you put the EKG at the higher intercostal space, in theories that maybe it closer to RVOT, because the RVOT, based on the depolarization theory that we talked about, could be the site where maybe, like Dr. Sunni mentioned, phase 2 re-entry and leading to arrhythmias. There's actually a study showing that there might be slow conduction in the RVOT. So basically, if you put the EKG in higher, you can see here, this is the baseline EKG, V2, in the fourth intercostal space, and V3, you see how it changes, and more significantly so if you put it in the second intercostal space. I mean, it's more obvious here. So that's one simple thing you can do. It takes a few minutes that you can do in clinic. Actually, just wanted to mention that type 2 and type 3 EKGs could be found in the general population. So it doesn't mean necessarily that the patient has Brugada syndrome. It's found in about, I think it's 11% of at least 9.9% of other patients when V1 and V2 were placed in the second intercostal space. So you have to take this with a grain of salt. I've seen, had consults for like 2 patients. One was an athlete, and they showed me the EKG. It looks like a saddle-shaped appearance, EKG, suspicious of Brugada, but we discovered that the nurse, rather than putting the EKG in the fourth intercostal space, which is a common occurrence, they put it higher up without even counting the intercostal space. We've also seen another guy who fainted, and then EKG showed the Brugada appearance, and when we went there, we put it in the proper position. You can't see it there. It looks like a normal EKG. So again, make sure that the position of the EKG is in the fourth intercostal space. Use that as a baseline. If there's a suspicious type 2 pattern, then yes, you can put it in the second and third intercostal space. So what else can be done? You can do a challenge test. Like we said, sodium channel blockers. If you give a sodium channel blocker, it will worsen. You'll have more loss of sodium channel functionality, and therefore Brugada ST elevation will be more apparent. So you can see here, this is the control baseline, kind of a saddle 2, type 2 pattern EKG. If you give procainamide, very obviously here, you can see a type 1 pattern. Quinidine, on the other hand, has an anticholinergic effect. It's an ITO blocker. That's why it acts and helps in Brugada syndrome. If you block the ITO, you'll have a longer action potential, thereby maybe use more your sodium channels, and then you'll have less ST elevation. So quinidine acts is one. That's why quinidine is one of the treatment options. Procainamide can be used as a challenger. So flecainide, also another agent that you can give to induce a type 1 pattern. I wanted to share this with you because this is something I found. The prevalence of Brugada type ECG pattern and early ventricular polarization in Tunisian athletes. So this is probably the closest population to Libyans. And interestingly, the prevalence of a type 2 EKG in type 3 was around 1.66 percent, 1.6%, 1.7%. Kind of a bit high. I mean, there was a Finnish study from Finland that showed the prevalence of about less than 1%, maybe 0.6%. So I'm wondering if we have more Brugada type EKGs, maybe type 2 or 3 in North Africa. Actually, type 1, spontaneous type 1 was 0% in this study. Early reparization, 22% actually, interesting. But that's another topic. We're not going to talk about that today. But just my message is basically that we definitely have Brugada patients. It's not really limited to Southeast Asia, where it was described and shown that it's very prevalent there in certain parts like Thailand, very higher prevalence. But it's also could be present in the Middle Eastern population. Actually, in Iran, it's 2.2%. There was an Iranian study that showed it's 2.2%. Okay, so we can go, yeah, so what's the next step? Still in case 2, this gentleman who's from Southeast Asia, he's from China, so he's an Asian guy and has some dizziness. His EKG in the right precordial EKGs didn't show a type 1 pattern. He has some symptoms, so what would you recommend? What's the next best step? ICD, among those choices, there could be other choices, but those are the ones that I wanted to put forward. So ICD, Holter monitor, event monitor, reassure the patient. He's been having symptoms that occur every few weeks. Okay, I hope that everyone has voted. Khalid, you can close them. Okay, so yeah, event monitor, I agree. ICD, probably not the first choice because we're not really sure what the symptoms are. He has very vague symptoms, a bit dizzy, has some palpitations. I would, and then we couldn't, I mean, you don't want to put an ICD unless you induce a type 1 spontaneous pattern. And so if you, one of the next steps you can consider is doing a challenge test, propanamide or flecainide challenge test. If you have a spontaneous type 1 pattern, then if an event monitor or some monitoring shows VT, then definitely an ICD is recommended. I would recommend this for this guy an event monitor to look for any VT, try to understand what's going on when those episodes happen. If it shows some sustained VT or that spontaneously terminates, then that's very worrisome. So I think the best answer would be an event monitor in this case. Okay, we'll move on to the case number 3, the last case. 20-year Caucasian male was found unresponsive. Actually was using drugs, no drugs found, but he had the paraphernalia, which is basically evidence of using drugs. There was equipment that he was in, needles and things like that. That's just that he was using drugs. 12 lead EKG was done when it was presented in the ED, and this is what it shows. Please take a look at the EKG and then we'll vote. As I mentioned, if you'd like to take a closer look at the EKG, just click on that magnifying glass in the middle of the image and you'll take a closer look. Choices will be a stat, left heart cath, bedside echocardiogram, urine drug screen, or an EP study. Okay? So stat, left heart cath, I agree. I mean, there's really no indication. Doesn't look like a typical ST elevation. Though he had, unfortunately, had a left heart cath. Bedside echocardiogram wouldn't be of any benefit in this case. So urine drug screen is the best choice. I agree with urine drug screen. This would be the first step. EP study. I mean, this patient was exposed to drugs. I wouldn't really jump to an EP study, but first would be do with a urine drug screen. There's actually cocaine has been described to cause a Brugada type pattern EKG, a type 1. And so this is the specific drug I'd be looking for. His urine drug screen actually was done and was negative for cocaine. There are other drugs actually, tricyclic antidepressants also have been described to cause a type 1 EKG, but that was not performed. So we don't really know why this happened. Actually, this is his EKG a few days after. Looks like it's normalizing. And this is the next question here. What does this EKG show? So if you, Khalid, if you can start the poll, please, voting. So this is the EKG 2 days after the patient was intubated. He was in comatose. So the choices are right bundle branch block, lead reversal, right ventricular hypertrophy, WBW, pre-excitation, or you choose 1 and 2. Okay. So no one chose right bundle. 8% chose lead reversal. This is one of the correct answers. RVH none. WBW. I don't really see any evidence of WBW in this EKG. There's no pre-excitation pattern, no short PR interval or delta wave. I mean, he's a bit tachycardic. He may have shortening the PR interval, but not significantly to be consistent with the pre-excitation syndrome. Then the other choices were 1 and 2. He has kind of a incomplete right bundle pattern. I think the most important action, definitely there's lead reversal. AVR here you can see was switched with AVL, resulting in the right axis. There's a kind of a right bundle pattern, so choices would be 1 and 2. I wanted to mention quickly about that can cause Brugada pattern EKG, which can confuse the physicians initially. That the patient, especially the ED physicians, would be very concerned about Brugada. But if the patient has been exposed to drugs, that's not necessarily the case, that they may have Brugada syndrome. Those drugs are tricyclic antidepressants, lithium, which is, of course, a sodium channel blocker, propofol also has a sodium blockade effect, cocaine, antihistamine, really the older antihistamine, the first generation has been described to cause a Brugada pattern EKG, calcium channel blockers, and diltiazem, cardizem combined with nitrate has also been described, but maybe a couple of case reports, not really the typical drug that would cause Brugada. And then the local anesthetic bupivacaine has been described to cause a Brugada pattern EKG. Now, what's the value, and does it mean that the patient has Brugada syndrome? I mean, if the patient has a baseline type 2 EKG or type 3 EKG, and then you give him a sodium channel blockade and becomes a spontaneous type 1, a type 1, induced type 1 pattern EKG, then maybe it's something that needs to be considered, looked into. But in this case, it's kind of more looks like a right bundle-ish. So patient, I think this patient doesn't have Brugada. Unfortunately, he expired. He passed away. Didn't make it. So all I did was actually, I mean, we couldn't do a challenge test or anything. He was in the ICU. All I did was just put his do a right precordial EKG, didn't show a type 1 pattern. So the guy unfortunately passed away a few weeks later, and that was put to rest. But if you encounter a patient like this, always think about, I mean, there are so many things that can cause, or things that could be considered differential diagnosis of Brugada. Hyperkalemia, I mean, electrolyte disturbance in general is something that you need to rule out. Look at other reversible causes, drugs, before committing and saying that the patient has Brugada syndrome. Family history can also help. I mean, this is something that has to be individualized based on the presentation. In this case, I think there's no need for further testing. I mean, okay. So, what's the cause of death in this patient? We can go next to the questions. I mean, he had brain damage. The guy had some anoxic brain injury. He was down, looks like, for some time. So it wasn't really the VT or VF arrest. He passed away while he was in the ICU. So it's not non-cardiac.
Yusuf, thank you very much for the review. I think we have 5-10 minutes time for questions, and I'll probably start just making a few comments. First comment is for people practicing maybe in Europe or some part of North Africa. So for in North America, you usually use procainamide for a challenge test, which is not available in some of the European countries. So they use flecainide, or the most expensive version is ajmelin. Second point, comment is you nicely showed in your slide that the mechanism is to do with the membrane action potential, and specifically the epicardium in the RBOT regions. And there is some, I think, data suggests that maybe ablation in this region is beneficial. But the data is one, I think, single study, which is with small number, and it's not a randomized trial. So it's still early to make any conclusion, but it's always tricky, Yusuf, isn't it? I mean, these patients, especially, I mean, when you have someone with spontaneous type 1, it's easy, straightforward. But when you have someone with syncope and type 2, then it's tricky one. Some people don't believe in the role of EP study, but you mentioned this article by the Brugada group. But I always find it difficult with the type 2. I would say that type 3 now is no longer considered as clinically relevant. In fact, some physicians go as far as not calling it type 3. But it's the gray zone I think is the type 2. I don't know if there's any questions by the audience. Anyone?
Yeah, Khalid, I mean, type 3 pattern could be found in the general population. I mean, also type 2, does it have any value? I mean, is there something that we need to do about if the patient doesn't have symptoms? I don't think we need to do any challenge tests if the patient is asymptomatic. Just leave it there, maybe with some follow-ups with a general cardiologist, or just mention to the patient that he needs to be followed up. If he have any symptoms, then needs to come back. Otherwise, we'll be doing a lot of testing for that. Yeah. But definitely, it's the spontaneous type 1 is really the kind of gray zone. If the patient is asymptomatic, that's where the challenge is. So,
I think Dr. Sunni Nadia is raised her hand, so I think let me just give her a chance to.
There's a question by Abdul Ghani Abu Nawara that family screening. Can I answer that real quick?
Yeah, of course. Yeah, while we're trying to get Nadia to.
So if someone has Brugada syndrome, so family screening, of course, we would screen the patient, prove that it's Brugada. If it's positive, then, I mean, first of all, actually, we get EKGs for, his brothers, sisters. If the patient has children, then, kind of more of not, I'm not sure if there's an age, a cutoff age, but not like a 3 or 4 year old. I don't think I would do an EKG on a 3 or 4 year old, but kind of older children, then we get an EKG. And if the patient has a positive genetic test like a proband, then we can test the family members and see who is autosomal dominant. If it's transmitted, it's going to be autosomal dominant. So that's a 50-50 chance. So I hope I answered the question.
And Nadia, do you want to make any comment?
Can you hear me? Assalamu alaikum.
Alaikum salam.
Very nice overview and presentation of kind of unusual ST elevations. Just wanted to say, in practice currently in the UK especially, because we know that coronary artery disease is much more common than Brugada syndrome, and especially in someone who has a premature family history of coronary artery disease. I'm going to play devil's advocate here, and I'm going to say if this, and just to kind of be controversial, and I'd welcome other people's comments. But in someone who has chest pain, be it atypical or not, with this ST elevation, I would visualize the coronaries, be that with a left heart cath or with a CT coronary angiogram. I have personally had a patient with typical type 1 spontaneous Brugada ECG who had a circumflex occlusion. So maybe it's because of my experience, but I would definitely exclude coronary artery disease before labeling it as Brugada. It is a typical looking ECG, but I have had it with coronary disease. Second comment that I would kind of like to make, and it's useful to bounce ideas off each other because we run into difficult scenarios. So quinidine. The use of quinidine, yes, in the guidance, it's more for VF, VT storms in the Brugada population, but it is also used in the youngsters who are bridging to have an ICD or who refuse to have an ICD. So I wonder, welcome your thoughts on that, but I have used the quinidine in patients who have refused an ICD. And as you mentioned, you're really stuck in those patients that are spontaneous type 1, that are Brugada, we can't use family history of sudden cardiac death and Brugada as a risk stratification marker. And we know that these 30-year-old or however old, 40-year-old patients, their risks of having complications from their defibrillators probably outweighs the ICD and the protection that it provides in someone who has not had documented ventricular arrhythmias. So I bounce that back to you, and I would look forward to your discussions. Thanks.
Thanks for your opinion regarding ST elevation. And definitely, if the patient had more typical symptoms like exertional chest pain, risk factors other than family history, I would have considered a stress test. But specifically in this patient, I didn't really feel that he needed this. He had actually stress test a couple of years ago, maybe 3-4 years ago. It was negative. I didn't feel that he needed it. But if there's any change, I might discuss with him next time when I would see him. If I might look into more if his symptoms sound more typical. I really use the pre-test probability. If the problem is I've ordered stress test and it's positive, the guy ends with a left heart cath that he doesn't really need. That's the issue that I run into. I try to avoid. I always look at pre-test probability regardless of how the EKG looks like, unless it's really typical for ischemia. Look at the age, sex, and how typical the symptoms are. Really typical symptoms, and he's 40 years old and he's a male. I would order. It would be more of kind of more intermediate to high risk. I could have ordered the left heart cath versus a stress test that could be discussed with the patient. But in this case, I didn't really feel that he needed a ischemic workup. And he exercises. He exercises and he does okay with exercise. So that's the second one. But it's a good thought. Thanks for sharing your experience with us. Then the number 2 is quinidine. Yeah, I completely agree with you. Quinidine could be used in. I don't have an experience with peds, so I can't comment on that. But with patients who are not candidates for ICDs or they refuse ICDs, definitely quinidine is the next best step. I agree. Quinidine could be used in Brugada syndrome, but after an ICD has been excluded, then 30-year-olds, I think actually the patients who would benefit from ICD and primary prevention or even secondary prevention in Brugada syndrome would be those patients, 30, 40, because risk of sudden cardiac death is actually highest at 40 years, around in the decade. If someone is 60 or 70, I wouldn't even talk about an ICD, unless they had sudden cardiac arrest because of Brugada syndrome. But I think the highest benefit would actually be for ICDs in this age group, 30, 40 years old. That's the time for them to get an ICD based on the presentation, based on risk stratification. Any thoughts, Khalid? Or,
I'll make a few comments if Fatih wants to join us or any other member of the audience. Regarding ruling out ischemic heart disease for the patient, I probably, I'll be honest, if I was his physician, probably, it depends if I feel I'll assess the patient risk factors and type of pain, but almost always I will kind of do an ischemia workout. Probably if I think the risk is very low, then I'll probably just go with CT angiogram, because you really it's Brugada syndrome is one of these tricky gray zone area where you have to make life-changing decisions on someone's life. So I think, but I agree with you, the likelihood of being ischemic heart disease is probably low, but I would still probably do CT angiogram. Regarding the second point, quinidine, I think for my patient who refused ICD, I tend to, since the data came out from the Brugada group, I tend to, if patient with spontaneous type 1 ECG refuse an ICD, I tend to push them more toward an EP study, and I find it that most of the time an EP study kind of help you make the decision and maybe patient change their mind. I always wanted to be in the patient position. Would I wanted an ICD, or would I want to taking the risk of ICD implantations, or I don't know. I usually push for an ICD, I'll be honest with you. If it's spontaneous type 1, I always push for an ICD if they have symptoms, and if they refuse, I try to encourage them to do an EP study. Subcutaneous ICD is always something I offer for any young patients with no indication for pacing. So I agree with Dr. Sunni who raised that point. I think this is where I feel subcutaneous ICD is really, it has a place. So my rule of thumb is any young patient with no indication for pacing always should be offered subcutaneous ICD. I was reluctant to do that initially, but since the new generation of these devices are getting smaller and smaller, and considering your next generator change will be even more smaller, I kind of become a fan of these devices. So I don't know if you agree, Yusuf, or...
Yeah, I agree with sub-Q ICD. I recommended a sub-Q ICD if the EP study was positive for this patient, but it was negative. But I would like to add, just keep in the back of your mind that Brugada patients may also have sinus node dysfunction, because the genetic abnormality in this SCN5A may also overlap with sinus node dysfunction. I think there was some, I mean, I can't remember on top of my head, but it's not an app. It doesn't mean that the patient would need a pacemaker or a pacing indication, but bear in mind that some patients may also have sick sinus syndrome. They may have atrial arrhythmias. Actually, there was a patient that we saw at the, he's a patient of one of my partners, and he had the flutter ablation 2 years ago. He presented with atrial flutter. He had a flutter ablation, and he's an athletic guy. He was running and collapsed. He was lucky that there was someone was there. They resuscitated him, came in, EKG kind of atypical. We did the challenge test, and it was kind of very subtle. And then, interestingly, when he exercised during the recovery period, ST elevation was very apparent. They had a spontaneous type 1 during the recovery period, ended up on an ICD. He had a twin brother also who had an ICD put in, and then was shocked 3 or 4 months after. And those patients actually, there's specific genetic abnormality. On genetic testing, there's an association with atrial arrhythmias, sinus node dysfunction. So just wanted to add that. But definitely a sub-Q ICD is the best option for those patients.
Okay, Yusuf, thank you very much. I think we have to move on to the next presentation. Sure. But I think I just saw a comment from Nadia. We will discuss toward the end. But I think if I have a patient with type 1 and some symptoms not typical, I'll probably go for an EP study. But for the sake of time, we're going to move to the next presentation. And it's my pleasure to introduce our second presenter, Dr. Abdulghani Abu Nuwara, who is a cardiac master university, who's going to talk today about stroke prophylaxis in patients with atrial fibrillation. And I'm really looking forward to reviewing the evidence and an overview of the use of the novel anticoagulant agents. Abdulghani, the floor is all yours.
Stroke prophylaxis in atrial fibrillation is very common nowadays, and lots of controversies around this topic. So I hope I'll be able to go over it briefly and try to answer some of your questions. I would concentrate mainly on the newer anticoagulation agents, the so-called NOACs, but we'll go over a few things through this talk, and you can answer. You can also send your questions during the talk or leave them at the end, whatever you prefer. So this is my conflict of interest with the bear. I'll try to cover a few points here, including understanding the atrial fibrillation and its risk of stroke. It will be very quick. Discuss the importance of oral anticoagulation in patients at risk. Compare the novel anticoagulation agents with warfarin and aspirin, and review a real-life or real-world effect of oral anticoagulation agents. So let's start with this brief case. So 66-year-old lady, newly diagnosed by chest atrial fibrillation. She has no other health issues before, no obvious secondary causes, normal LV function, normal renal function, normal thyroid function, physical examination are remarkable. So what would you consider here? Shall we give anticoagulation for this lady or not? So just start with this question quickly, if you can answer here, and then we'll go over. Okay, I see the vast majority answered the right question, which is newer anticoagulation agents. Warfarin is still a valid option. It's not contraindicated, obviously, but I will try to convince you by the end of the talk that NOACs are indeed better than warfarin, obviously better than aspirin, and I would consider novel anticoagulation agent in this case. This is just for those who we have here. Sometimes we have medical students, so this is just a typical example of atrial fibrillation ECG. It's easy to diagnose. Sometimes it's not that easy, but obviously you concentrate on two things: regular rhythm and no P waves. Try to look for P waves everywhere, and try not to convince with frequent PACs or BBCs. So mechanism of atrial fibrillation, I will go over that probably later, but the prevalence of atrial fibrillation is very common with advanced age. You can see from this particular study that after the age of around 50 or so, the atrial fibrillation risk increases significantly, and the older the person, the higher the risk of atrial fibrillation, whether female or male. And obviously, the higher the risk of a stroke comes with atrial fibrillation. So if you have atrial fibrillation, definitely your risk of stroke is very high. If you have, especially if you have the so-called high CHADS score, an average about 5%. But I will go over that a little more shortly. So atrial fibrillation management, I would briefly go just over the rate and rhythm control. For anticoagulation, these are the new guidelines, Canadian guidelines, 2014. So always start with the age, patient above the age of 65. So no brainer, don't think too much, just give them anticoagulation, oral anticoagulation, if not contraindicated. If the age is less than 65, then look for the CHADS score criteria. If they have TIA or stroke, hypertension, heart failure, diabetes, then obviously you consider a novel anticoagulation agent. If they have none of the above, then look for other vascular disease like coronary artery disease or aortic aneurysm or peripheral vascular disease, then consider aspirin, obviously. If none of the above is present, then you may even just leave them alone, and that would be considered the so-called lone atrial fibrillation. And this is definitely made our life easier, so you don't need to think too much about when to use it or when to use it. Then it comes to which choice of anticoagulation you would prefer. To treat the atrial fibrillation in terms of controlling the rhythm itself or controlling the rate, then that also another topic, but just previously go over the American guidelines here, which is similar to the Canadian guidelines. Atrial fibrillation, look for other comorbidities like hypertension or LV dysfunction or COPD. Then you may consider one of the rate controlling agents first, preferably beta blockers. You may also consider calcium channel blocker if you can give it, for example, severe COPD, severe symptomatic COPD, or you may consider adding digoxin if the patient has symptomatic heart failure. If this fails to control, they consider rhythm control with one of the rhythm control agents, for example, amiodarone, if not contraindicated. And this is briefly about the rhythm control. So if the patient has structural heart disease or no structural heart disease, if you have no structural heart disease, consider one of the rhythm agents, or consider catheter ablation, electrophysiology study and catheter ablation. If you have structural heart disease, coronary artery disease, or heart failure, mainly for heart failure, you're limited to amiodarone and difetilide. Also consider EV study and atrial fibrillation ablation. Obviously, amiodarone if not contraindicated. So just a brief about the rhythm and rate control. So obviously, there's no difference in terms of rhythm or rate control from the firm trial, as long as the heart rate is less than 100. So in fact, atrial fibrillation rate control with the rate control medications is preferred to start with if you can control the rate with no statistical significance from the firm trial. So I'll go to the main topic now, to the anticoagulation for stroke prophylaxis and atrial fibrillation using warfarin or the newer agents versus aspirin. I will start with the CHAD score. We likely all know the CHAD score, which stands for congestive heart failure, hypertension, age, diabetes, and stroke. And just to concentrate on the event rate, which goes higher with the CHAD score. The higher the CHAD score, it's not only 5%, as I mentioned earlier on, that's only the average, but if the CHAD score is about 5 or 6, the stroke event rate would be as high as 18% per year. And also we use CHADS FAST, which is a little more specific. You add vasculature and age 65 to 74. Gender, female, is not considered anymore of that importance, but we always try to go with the new guidelines, which is starting with the age of 65 and go down to the through the algorithm. Don't forget to look for bleeding risk in those patients using preferably the so-called HAS-BLED scoring. And obviously there's overlap. So patients who have uncontrolled hypertension, the risk of bleeding is higher. If you have renal failure or liver failure, if you have previous stroke or previous bleeding, labile INR, old age, use of drugs like alcohol, these will put patients at higher risk of bleeding. But always we use the CHAD score or the algorithm first. So we try to use anticoagulation in all patients unless really you can't. And the reason why you use anticoagulation, we know the reason is the atrial fibrillation causes blood clot formation, thrombus formation in the left atrium, mainly in the left atrial appendage. And this is an example of transesophageal echo of the left atrial appendage. And that's where most of the blood stagnates here and causing blood clot formation. And the shape of this atrial appendage is different from patient to patient, but the risk of stroke is there because of the blood stagnation. And this is just an example of left atrial appendage thrombus on the transesophageal echo. And this can sludge and cause obviously massive stroke, or can go anywhere in the systemic circulation. We used to use warfarin before. That was the only anticoagulation agent for stroke prophylaxis. However, with the newer agents, we shy away from this drug because of the delay onset and offset of this drug. Unpredictable dose. Every patient, as you know, needs different dose. It's not a fixed dose. No therapeutic index. Multiple drugs and food interactions. Problematic monitoring. High bleeding rates. It's not without risk of bleeding. And also slow reversibility. Yes, there's antidote, which is vitamin K, but it's very slow to reverse, and usually it's too late after the damage has happened. And you see this is a very long list of drug interactions with warfarin. I won't go over this. And this is the narrow therapeutic range of warfarin. So INR has to be between 2.0 and 3.0 to get the best benefit with minimum risk of bleeding. If your INR is higher than 3, then the risk of intracranial bleeding will increase. Bleeding in general, but specifically intracranial bleeding without any extra prevention from ischemic stroke. However, if your INR is less than 2, obviously you are not protected. And for those who believe that antidote is effective for warfarin, yes, effective to treat ourselves because the INR is low, but the expansion of the bleeding side increases, especially if it's intracranial bleeding. This is when the INR is 3.6, and this is the INR is 1.2. Still, the bleeding is there. In fact, it's bigger than before, despite the normal range of INR, and the antidote has worked. So. Yes, there is antidote, but it's very slow, and usually happens. The reverse effect of warfarin happens after all the damage happened. So we used all the necessary measures to prevent rather than to treat bleeding. However, we still need to use warfarin. It's not contraindicated, obviously. And still a valid drug for certain patients, especially patients with renal disease, if GFR less than 20, patients dialysis, patients who can't afford NOACs because of the high cost. Some patients decline NOACs. Just they are new drugs. I don't want them. They are costly, and I would like to stick with warfarin. I'm happy with warfarin. So some patients you see from time to time like this. I have a few patients who can't tolerate NOACs for certain reasons. Patients need warfarin for other reasons, for example, mechanical valves. So they use it for the two reasons, for atrial fibrillation and also for the mechanical valves or other reasons. Now, a very common question about stopping the anticoagulation after minor surgery. Just a question that was raised by one of my other colleagues. I wanted to throw it here. So if the patient is going to have surgery like cataract, joint or soft injections, atherosclerosis, atheroscentesis, or minor procedures like skin procedures, when do you think you will stop anticoagulation? Is it in this particular patient or different? There is no need to stop in any of those situations. Just continue the anticoagulation. Depends on the comfort level of the surgeon, obviously. Here's the newer anticoagulation agents mechanism of action. So you have the apixaban and the rivaroxaban are factor Xa inhibitors, and direct thrombin inhibitor is dabigatran, which was the first novel anticoagulation agent. And we have also aldoxaban, that's the newer agent, which is also factor Xa inhibitor. And warfarin works on the other way, which starts from the intrinsic pathway. So these are the novel anticoagulation agents that we have now in practice. First one was the dabigatran, which is direct thrombin inhibitor, twice a day. It's cleared to the kidneys. So renal clearance. Rivaroxaban is the other agent, which is direct factor Xa inhibitor, once a day. We don't know why they just use it in the trial, and it's once a day, although the T half is more or less the same. But it's effective as once a day so far. It's also renal clearance. Apixaban is direct factor Xa inhibitor, also twice a day, and it's mainly hepatic clearance. So that's why we use it even if the GFR is around 25 or more. Edoxaban is the newer anticoagulation agent, which is approved nowadays in certain places. It's still not available in clinical practice in Canada yet. Hopefully soon. To start with dabigatran, we have evidence for that from this clinical trial, the Raleigh trial, which was the investigators from McMaster University. Again, they used two doses, 10 milligrams dose twice a day, and 150 milligrams twice a day, compared both to warfarin. And you can clearly see from these Kaplan-Meier curves that the 150 milligrams has more effect on stroke prevention than warfarin, and also better than the dose of 110. And the dose of 110, when compared to warfarin, they both were similar in terms of stroke prevention. However, dabigatran 150 has similar bleeding risk compared to warfarin, whereas the 110 milligrams dose has less bleeding risk when compared to warfarin. So if you have people who have high risk of bleeding, you can use the 110 rather than the 150 dose. And mainly it's GI bleeding, so you can use GI protection with PPIs to prevent that risk of bleeding. The other drug, which is rivaroxaban, or the other name Xarelto, in which we have available here in Canada. Again, it's once a day, and it's definitely as effective as warfarin, with less hemorrhagic stroke when compared to warfarin, and similar stroke reduction. Still no antidote, but the antidote is coming. I'm going to speak about that shortly. And you can see from the Rocket AF trial that rivaroxaban, when compared to warfarin, it's definitely better in terms of stroke prevention and event rate with statistically significant p-value. There is no mortality difference, but the event rate difference apart from that was in favor of rivaroxaban. The other drug that we have here available is apixaban, or other name is Eliquis, and was studied in this study, Aristotle study. And the dose we have available, as you know, is 2.5 and 5 milligrams twice a day. It's effective, and it has less hemorrhagic stroke than warfarin, similar reduction of ischemic stroke, but also it lowers mortality. So there's evidence from this particular drug that it lowers mortality when compared to warfarin. So it's one of the best anticoagulation agents we have available now for that particular reason, although the statistical difference wasn't huge, but it was clearly statistically different in favor of apixaban, that it reduces mortality when compared to warfarin, and that was a killer to warfarin. This is the primary outcome: stroke or systemic embolization. When compared to warfarin, apixaban has 21% relative risk reduction when compared to warfarin. Definitely, it's better than warfarin in my opinion, and it has to be used ethically unless it's contraindicated. And all of them can be as effective as if the clinical trial is used in certain way, but at least that's the evidence we have so far. In terms of major bleeding, you can see there's evidence that apixaban has less major bleeding than warfarin by 31% relative risk reduction. So you can say it's clearly safer than warfarin in terms of major bleeding. And to test safety of apixaban, Averroes trial came out comparing apixaban to aspirin, and that showed that major bleeding is actually similar. Apixaban and warfarin is similar. In other words, apixaban is as safe as aspirin if you use it, and that doesn't cause major bleeding more than what usually happens from drugs that we commonly use like aspirin. And that was really a surprise and a very good news to patients. And it's not only that, if you compare the stroke and systemic embolization risk, apixaban has a huge difference in terms of stroke and systemic embolization reduction when compared to warfarin. So you have a drug that is very significantly effective in terms of stroke prevention, with bleeding risk that's as low as bleeding risk of aspirin. I think that's a very effective drug so far, unless we have otherwise other evidence to show us different results. It's a question here: how does the age factor into the decision regarding a choice and dosing of anticoagulation? So if you have an old age or young age, depends on the age of the patient, would you increase the NOAC dose by half, or no need to change the dose, or decrease the NOAC dose by half, or give only aspirin to all patients age more than 80? What's the answer? If you can just vote now. Okay, so I have none choose to increase the dose. I agree with that. No need to change the dose. So it depends on the age, obviously. Age above 80, you need to decrease the dose by half, which is, I agree. The right answer would be number 3. But again, that depends on age. Age is an important factor based on which you may reduce the dose. Especially for apixaban, we use the cutoff age of 80. So here, always use the highest dose of NOACs if you can, unless reasons to reduce. So stick to the clinical trials doses, which is the recommended dose of, for example, apixaban 5 milligrams twice a day, dabigatran 150 BID, or rivaroxaban 20 once a day. So that's our recommendations. So the criteria when to reduce the dose is, for example, apixaban, you reduce the dose to half if the creatinine clearance is about 25 or so, and you may not even use it if it's less than 20% or 20 for the creatinine clearance. Age of 80, you need to reduce the dose to 2.5. And if the body weight is 60 kilograms or less, then you reduce the dose of apixaban to 2.5 twice a day. So these are the 3 criteria for apixaban when you reduce the dose to half: if you have age above 80, or body weight less than 60, or if you have significant renal dysfunction. Similarly with dabigatran, if you have significant creatinine, significant renal dysfunction with creatinine clearance, preferably not less than 30. We usually use about 40 for creatinine clearance. And also we use a cutoff age of 80 to reduce the dose to half to minimize the risk of bleeding. Obviously, if there's a previous history of bleeding or other factors that might, you think, increases the risk of bleeding, then you need to reduce the dose to half, but preferably to stick to the high dose, which is the clinical trial recommended doses. And also for rivaroxaban, you can go to 15 if the creatinine clearance is about 30 to 50. Just going to go to the real life studies. We have non-randomized studies just came out this year. I won't be able to go over them all, but I'm going to go over few of them, preferably this Xanthos trial, which is showed low rates of bleeding and stroke in real-world prospective observational study of patients treated with rivaroxaban for stroke prevention and atrial fibrillation, which was presented in the ESC in 2015 in London. And they, in this particular trial, they screened about 11,000 patients, enrolled about 7,000 patients. Safety population, again, was about 7,000 or so. And the dose of rivaroxaban used 20 milligrams once a day and 15 and other doses. So from this particular trial, they wanted to see if the drug is safe, and they want to compare these results to the clinical trials, not to another cohort of patients. So this is not a randomized trial. And you can see the Kaplan-Meier curves here. There's no comparison, but just to show you the real-life mortality and major bleeding and stroke And here is comparison between the two doses, 15 and 20. For example, thromboembolic event is better is obviously less with the dose of 20 milligrams. So that's why we recommend to stick to the 20 milligrams or the clinical trial recommended doses. Major bleeding is also less with that, and all cause deaths, interesting enough, is also less with 20. So we strongly recommend to stick to the higher dose unless you can't use the higher dose of the drug based on those real life non-randomized trials. I don't see here the whole. There was a curve that is available here. Not sure it disappeared, but anyways, when compared to ROCT-AF trial, Santos trial showed that actually risk of stroke was actually less. CHAD score was a bit less in real life, but definitely there is no major difference in terms of mortality or increase in risk of bleeding, because we felt that probably in real life the risk of bleeding or events will be higher with these new agents. In fact, they are lower, although they are not statistically significant, but they are lower than even in the real in the trials. So the conclusion from those trials are really safe drugs in real life. That was the main purpose of those real life non-randomized trials. Although we can argue on that you need more evidence with randomized trials to support this. Shift gears here for antidotes. Everybody is concerned about bleeding risk, and there is no antidotes available to encounter the bleeding from those new agents. I personally don't have a major concern about bleeding from those agents because we treat bleeding similar to any other causes of bleeding, even if the patient is on these new agents. However, for the sake of treatment, especially if the patient has life-threatening bleeding, then antidotes have been in the clinical trials. There are at least 2 or 3 so far. One of them is the so-called enderocizumab, which is monoclonal antibody, and it's antidote for the dabigatran. It's in phase 3 trial now. It's available. We have it here in McMaster under the with the clinical trial that's going on. It's not available everywhere, but it's available if a patient is enrolled in the clinical trial. Dose, we give 2.5 grams IV. We give one, and then you wait 15 minutes to give the other, total of 5 grams. It's very effective. Within a few seconds, the dabigatran will be out of the system, and the patient hemostasis will be back to baseline. So, for example, if the patient is going for surgery, within a few seconds, the anticoagulation will be shut down, and the patient can go to surgery within a few seconds. And then you can look for the reason why the patient has been having bleeding and treat the other causes. Other antidotes under development, which is enderoxanate alpha, it's still in phase 2 trial, and it's an antidote for apixaban and rivaroxaban. Just started phase 3, and it's also IV. We didn't have enough information about that. And also there are Fab antibodies for dabigatran, still also in phase 3 trial. We didn't have enough evidence for those antidotes, but hopefully the next few months or maybe a year or so we'll have more information about those drugs and safety and their cost and the route of administration. So far will be all IV, but I hope at one point you can get oral antidotes as well. Balance of stroke prevention, as I mentioned earlier, with the risk of bleeding. So always we keep in mind the stroke prevention first. Try to convince the patient to get the anticoagulation to prevent stroke because of its devastating results. And also keep in mind the risk of bleeding and try to prevent bleeding rather than to treat. For example, you can give stomach protection with PBI with patients who are at risk of GI bleeding in combination with the oral anticoagulation agents. Another question here, what can you do to decrease the risk of bleeding in the future? I mentioned some of that, but here it's except use one of the following except discontinue aspirin, non-steroidal anti-inflammatory drugs, measure and monitor renal function, avoid co-prescription of PBI, and provide mobility aids. It's an easy question. Okay, so what can we do to decrease bleeding? So we want to decrease bleeding. Do all the following except. The answer is 3, obviously. Avoid co-prescribing PBI. So accept that. So you shouldn't avoid. Should use PBI if needed. So if you have a patient who has history of peptic ulcer disease or previous history of GI bleeding, so to decrease the risk of bleeding, you should use PBI. Obviously, provide mobility aids to minimize risk of falls and injury, measure the renal function to, if the patient develops renal failure, that will increase the risk of bleeding because of the increasing concentration of the drug, and also discontinue aspirin and NSAIDs if not necessary. Those will minimize the risk of bleeding. So the answer is 3. Here's a brief approach to what to do when we did your best to prevent bleeding, but the patient comes with bleeding, and this happens to everybody. So patient comes with bleeding while on NOACs. If the bleeding is minor, so just delay the next dose. Mention to the patient the increased risk of bleeding with any delay in the dose of anticoagulation, but also to minimize the risk of bleeding. And if the bleeding is moderate to severe, there are ways to measure the bleeding. For example, if the patient has severe profuse bleeding or the patient requires blood transfusion, hemoglobin less than 70, those are severe bleeding. In between is moderate, or if you have just minor cut or a little bit of nasal bleeding, that's minor or mild bleeding. So if it's moderate to severe bleeding, we obviously do mechanical compression if possible, surgical interventions, fluid replacement, blood transfusion, and blood products, and even may consider hemodialysis for dabigatran, and use the PCC, prothrombin complex concentrate, which can be used to provide the anticoagulation factors. It's not to reverse the drug, but this to increase the anticoagulation agents or factors, to increase the coagulation factors by giving the PCC, and that hoping that will reduce the bleeding. And the main thing is to treat exactly the source of bleeding. And if it's intracranial bleeding, obviously you'll discontinue the bleeding, the anticoagulation agent, and reassess the bleeding source frequently. If it's life-threatening, so you may consider factor 7A or PCC, ultrafiltration, and hemodialysis, obviously, and surgical intervention. So if it's life-threatening or moderate to severe, probably the treatment would be the same. Discontinue the anticoagulation agent and do your best to treat. And this, by the way, is not only with newer agents, it's also with aspirin and Plavix and with warfarin. And even if you give vitamin D, you can just reduce or decrease the INR, but the bleeding risk is still there, definitely less when the INR is less than super therapeutic, but still the bleeding risk is not zero. I think we're at the end here to conclude. NOACs for stroke prevention and atrial fibrillation have superior safety and efficacy profile. I would conclude that also risk reduction strategies are very important by using CHAD score and as split result in patients using NOACs safely, and antidotes and reversal agents are being developed, so hopefully that will help to minimize the bleeding and to treat the bleeding. NOACs appear to be safe in real life and real world, so I hope I have some evidence for you guys to convince you to use NOACs more and more for those who do not use them, and to encourage those who use them to use them more. Just quickly, I'm going to go over Dr. Nadia Sunni note here. What would you do to management of acute phase in over patients? I think I just went over that, Nadia. I would consider the same measures, what to do to that, just to probably when to restart the anticoagulation agent. I think that was what you meant, Nadia, is to restart the anticoagulation agent is a different story once you feel safe. I prefer to use the anticoagulation agents as soon as possible, and in collaboration with other people like neurosurgeons, neurologists, GI people, depends on the source of bleeding, to use the left atrial appendage occluders might help to reduce the risk of stroke, but still there's no strong evidence to help us to decide about that yet. I would continue with the same management for now with NOACs until we have more evidence for those occlusive agents to support the use of them in replacement to NOACs. And we definitely have them available in clinical trials, and we have a few patients who went through that, but still you're really afraid that they may develop blood clot formation in the left atrium itself, not only in the left atrial appendage, and they end up with stroke. So we need to have more evidence. Yusuf, do you have preference of specific NOACs? Yes, I prefer apixaban. That's my personal opinion because of the mortality benefit. However, you can use any of them safely. All of them are effective. All of them have safe profile, and they reduce the stroke and the systemic embolization either similar or better than warfarin. So if you are comfortable with apixaban twice a day, if you want to use once a day, rivaroxaban. If you have patients with DVT and PE, use rivaroxaban. You may use apixaban. It's approved nowadays also. So you may select your patient based on the other comorbidities of your patient. Obviously, you need to stick with warfarin if you have a patient with mechanical valves. So maybe I'll open the floor to verbal questions. Khalid, thank you, everybody.
Thank you, Abdul Ghani. This is really a very interesting overview. As I expected, it generated a lot of interest, and I could see the question starts to flow. Let me just read one of the questions, Abdul Ghani, is Dr. Adib, is AF percentage play a role in the treatment? I assume he meant paroxysmal persistence or percentage of AF. Do you have any preference, or do you treat them all the same with regard to anticoagulation?
Yeah, exactly the same. Yeah, even if they are ablated, if you want to do ablation and successful ablation, still the guidelines say you need to treat them the same. You need to use anticoagulation long term until we have more evidence. Old age, still we have very good 90s. I have people like 90 years old who run every day and who looks like 70. So age is not the factor. I think you may use frailty as a cutoff point. You have patients say 70 and has stroke and he has no quality of life whatsoever. You may say, we'll discuss with the family the use of anticoagulation, that particular, rather than to deny a 90-year-old who is very active and wants everything to be done. So you may consider reducing the dose of anticoagulation for patients like age of 90 or so to half, but not to deny them from receiving the anticoagulation agents.
The other question, Abdulghani, which I actually wanted to ask you the same question is Dr. Abdul Wahab Naas raised that. So it appears that in Canada, you look at the age first, and if they are above 65, you give them warfarin or NOAC. If not, then you use CHAD-2 score rather than CHAD-VAS score. Is that correct?
Yes, that's what we have in Canada now. Based on our guidelines, we use the age which is 65. And if you have age 65, then you stop there. Don't think about anything else, looking for a reason to give anticoagulation. And then you have a reason to give anticoagulation, so that's clear. Then you look for the CHADS, obviously, CHADS score to help you to say this patient has higher risk of stroke than this patient. So his ACE, both are 65, but this CHADS score is 6 and this CHADS score is 1. So I know that this patient has high risk of stroke with CHADS score of 6, so about 18% per year, whereas CHADS score 1 is about 5% per year. That helps you to know that information, but not when to initiate the anticoagulation. So both they need it, and both you should give them long-term anticoagulation regardless. And also keep in mind the has-bled score, which is the risk of bleeding in those particular patients, and you can adjust the dose based on that. Maybe Khalid, if you want to ask them to, if they want to answer, to ask directly, if they want, and then you can read through them.
Yeah, if anyone wants to take the mic, please feel free to raise your hand, and it's probably better if you take the mic and ask. But while we're waiting for people to raise their hand, I just to make a comment about this. Obviously, I have experience in the US and the UK, and it's different to Canada, because the reason why we consider giving anticoagulations, either you have a high CHAD-VAS score, or if you considering patient for AF ablation. So I think that the practice in the UK and in the US is somehow similar, but obviously clearly different to Canada. There is a question from Yusuf Adarat, and I think it's specific for electrophysiology, so I'm happy to answer that question. Is what's your experience with NOAC in flutter ablation and AF ablation? I use a lot of Xarelto, rivaxapan, uninterrupted, and I had really good experience with it, and the data is there to support it. Dr. Natalie Group published extensively using rivaxapan, and it's proven to be safe. You don't have to stop it. I started using apixaban, so I'm becoming more comfortable with apixaban, but I would definitely not recommend using the bigatran. There's a lot of data to suggest it's probably not as safe. So from my experience so far, I feel very comfortable using rivaxapan for the AF ablation. I'm getting more comfortable using apixaban. I think there is Dr. Yusuf Adarat raised his hand, so we'll give him. Yusuf, do you want to ask a question directly to Abdulghani? Okay, sorry. So he's not raised it. There's another question, Abdulghani, from Dr. Adil Al-Muntasir. He says, can you make any comment about the use of NOAC with amiodarone?
Yeah, you can use it, no doubt. There are lots of interactions with amiodarone, unfortunately. More with warfarin, though, because you need to check the INR, and it affects the INR more. With NOACs, we just continue with the dose that you're giving, and give the amiodarone as usual. We don't have particular recommendations about the dose of NOACs with amiodarone. We don't like amiodarone itself, unfortunately, because of its safety profile and lots of side effects. But if you need to use it, just the usual way. There's no specific recommendations so far.
I think there is a question by Dr. Nadia Sunni is, what do you define as an AF episode which warranty anticoagulation?
Oh,
7 seconds.
well, it's very controversial, and we don't have evidence for that. The evidence we have so far is 30 seconds. We use 30 seconds here. Some people use 6 minutes. We got definitely not 7 seconds. We don't use 7 seconds. 30 seconds, and obviously go with the chat score, with the algorithm, with the called chat 65 score now. So if you have evidence of atrial fibrillation more than 30 seconds, you clearly can convince the patient to start the anticoagulation.
There is a question by Dr. Adarat, is comment about the Everest trial. Does it recommend starting apixaban even in patients with low CHA2DS2-VASc score?
These questions are answered in our guidelines by the new algorithm. So that's why I said use the age of 65 as your cutoff. That saves you from lots of headaches and questions. And then you go with the CHA2DS2 score after that. And again, CHA2DS2 score helps you to define those patients who have high risk of stroke versus those who are at low risk of stroke. And just you may need to be more careful with those patients who have high risk of stroke in terms of interruption of anticoagulation, in terms of, for example, if they need surgery, you shouldn't interrupt them for any minor surgery. Whereas if you have CHA2DS2 score of 1, you may say safely, okay, you can stop it for a day or two. So that helps you a lot. But in terms of initiation of anticoagulation, I would stick to our guidelines. It helped us a lot and saved us from lots of questions. We're protected by these guidelines.
Dr. Riyad Al-Karudi, I think he was asking whether you could use the NOAC for patients with mitral valve disease and AF patients.
Well, it's still controversial. They say it depends on how bad is the mitral stenosis. Mainly mitral stenosis, obviously. If you have severe mitral stenosis, we prefer to stick to warfarin. We don't have strong evidence yet, but we consider it as valvular disease. I still use NOACs for all of my mitral valve disease patients who have mild to moderate disease, and especially if the left atrium is not severely dilated, especially if there is no previous left atrial thrombus. That helps us to decide about the use of NOACs. So I still think using higher dose of NOACs is safe in valvular heart disease. If you're not comfortable, consider warfarin, just like mechanical valves.
I think Dr. Anas asked a question about any preference of the NOAC in the elderly group, let's say above the age of 80 years old.
Above the age of 80, there is no specific. I particularly prefer apixaban, just because of its safety profile when compared to aspirin. We have Averroes trial. That's the evidence we have now. It's as safe as aspirin, and it's way more effective than aspirin for stroke prevention. So I personally prefer the small dose of apixaban 2.5 twice a day.
Okay. I just, while there's another question, but I would like to ask you a question myself, Abdulani, is I'll tell you what's my favorite NOAC, and I'll explain to you why, and I would like to share your view and value your opinion about it. I personally prefer a once daily dose because I know most of my patients will be more compliant. Secondly, which interests me always from a molecular biology point of view, rivaroxaban and apixaban, they are very similar molecules. In fact, apixaban probably have a slightly longer half-life. You showed in your slide is about 8 to 15, whereas rivaroxaban is, I think, 5 to 9 hours.
Nine, yeah.
Yeah, 9 hours. And still, rivaroxaban is used once a daily and apixaban twice a day. I think it's mainly because of the design of the trial. And I don't think the company wanted to risk one dose daily. I don't know, what's your view? Do you have any comment about that?
I agree, totally agree. Yeah, I think it's mainly the trial design. They should have used smaller dose of rivaroxaban twice a day, or they should have used higher dose of apixaban once a day, so that we can make those two drugs even. you can see clearly from the T-half of the rivaroxaban, it's actually shorter than apixaban and dabigatran, yet use it once a day. I think the bleeding risk might be a little higher with this high dose of apixaban, not apixaban, rivaroxaban once a day, but we don't have evidence for that yet. I think I have heard that there's a trial coming now for rivaroxaban twice a day to compare to once a day and see smaller dose, like I think it's 2.5. But again, it's a personal preference. The reason that I prefer apixaban is the mortality benefit, because you have evidence that it reduces mortality when compared to warfarin, whereas rivaroxaban doesn't. Bleeding risk, all of them are comparable. Safety, apixaban, we have evidence that's safer than others, and compared to aspirin. We don't have that similar trial with others, so it's not fair to say those other drugs are not safe. We go with what we have now. What we have now is apixaban is safe and similar to aspirin. It's effective. Yes, twice a day, but you don't need that hassle of INR every other week or every 3 weeks. So that's a big advantage of apixaban. Hopefully, we'll have antidotes that the question of antidote will be out of the way. And again, it's a personal preference. I agree. You can use any of those. Even dabigatran, still it's a good drug, although it has some issues with it. But you can use any of those. Still are effective.
There's a question from Dr. Nasser Shri, I think. Is there a blood test to measure the level of NOAC? I'm not aware there is any.
Yes, we have. We do it in the clinical trials only. So, like for example, now when we have the trial for the antidote of dabigatran, we measure the drug level after 15 seconds. So we take a sample and drink. It's a very expensive test, and you see the difference after if you give the second dose of the antidote. You see it goes almost to zero. But it's not effective. I mean, it's not practical, I would say. It's very expensive and won't be available anywhere. And there is no surrogate marker like INR and BTT. INR and BTT can be elevated if the dose is very high, if the anticoagulation dose is very high, or the patient has for example, drug overdose from NOAC. We have few of them. INR will be very high and PTT also very high. We see it more with rivaroxaban, obviously, but there is no clinical, practical test that we use to measure so far for us, only for clinical trials.
The other comment is we probably didn't cover the newest agent in the market, which is edoxapan. But I think edoxapan has the potential to be the dominant one. Obviously, we still don't have real life data, but it's once daily. It's you don't have to take it with food. Potentially have similar benefit and low risk of bleeding. So I'm curious and interested to see what's the real data, but obviously we won't have that answer yet.
It's effective, yeah, I agree. It's very effective. It's available in Japan now. They use it like first line in Japan, and it's very effective. I agree. I hope it will come, and if you have evidence that's better than apixaban, it will dominate because it's once a day. The only thing is we need mortality benefit. I hope we'll have mortality benefit evidence for that.
Yeah, I think it's in Europe. It started to be used. In fact, in last month it was approved in the UK. So now we can use it. In fact, I'm interested to start a trial using it for cardioversion. So I'm curious, and I would be interested, but we'll see. I don't know.
Also approved. I think it's approved. Health Canada is looking into the approval soon, so it will be. It's coming. So it's.
I think it's been promoted by a Japanese company, and it looks like they're pushing. And
agree.
They at least got the UK approval now. Well, I think it was really interesting. Generated a lot of discussion and a lot of interest, obviously. Oh, we have one more question. It looks like Dr. Anas have a female age less than 75 will score 0 using CHAD. Well, yeah, I think this is what Dr. Anas is trying to point out. Is obviously we know the CHAD-VAS score is probably it's commonly used now in the UK and US. It's explored these patients where the female who are elderly, they obviously score higher. I think everyone is moving to CHAD-VAS score, but obviously Canada is still CHAD-2. But I agree with you, Dr. Anas, there is difference using CHAD-2 and CHAD-VAS score. But overall, I think you have to take every patient.
Yeah, just quickly about this female gender is not an issue anymore. There's evidence that it was added to the CHAD-VAS, but we don't really pay attention to that anymore. We pay attention more to the vascular disease or peripheral vascular disease or CAD more than the age gender. So we actually jumped with the age now from 65 to 75 up to 65 in the upfront, and we left the vascular disease, and we don't consider the age, the gender difference anymore. So just take it out of the equation. Still, you can use the CHAD-VAS, but not to be worried about the gender difference.
I think that that's to be honest, Dr. Anas, is their criteria is if you are above the age of 65, you qualify anyway, so it doesn't matter.
Exactly.
I guess it's every country it has to follow that guideline. I think we have to put an end to an excellent, really enjoyed the webinar today, generated a lot of interest from the audience. Thank you very much, Abdul Ghani. Really appreciated your effort, and very hot topic and very interesting topic. Also, thank you to Dr. Darat for his excellent presentation, and thank you all for attending today. I just want to remind you about our next webinar. I really appreciate it if you could join us. We already have 2 excellent speakers lined up for that meeting. And Dr. Darat probably is going to send you an email soon, but the date to put in your calendar is the 22nd of November. Hopefully you'll get an email in the next few weeks from Dr. Darat to remind you all. Once again, thank you everyone for coming today, and thank you to our presenter. Thank you very much.
Thanks. Bye.